Mm. Hey everyone, thank you for joining. We're just going to give it another minute to let people in. Thank you all for joining. We're just going to give it one more minute. If you're interested, I believe the chat functionality is working for everyone tonight. If you want to say hello and let us know where you're coming in from. Oh, thank you, Kathy, for starting us off. I know that we have some participants from all across the US, so feel free to let us know where you are. See, the Bombas Giving team is here. Okay, I think we'll get started. So welcome everyone. Thank you so much for joining this evening. We're so glad that you're here. My name is Kelly Cobb. My pronouns are she, her, and I'm the VP of Giving at Bombas. I have the privilege of overseeing the way that mission intersects with everything that we do at Bombas and of working closely with the homeless community in New York City. I'm so glad to be able to host this discussion around the topic of healthcare, public health, and homelessness with these incredible folks from Boston Healthcare for the Homeless program. An hour always goes by very quickly when we're getting into the complexities of these topics, but we will continue to have conversations just like these, inviting all of you, our team, our customers, and community to be a part of it. This is the sixth conversation in our ongoing speaker series. We'll continue to host one every month, digging into the many topics that intersect with homelessness. So we hope you'll keep coming back to learn with us. And if you haven't joined us before, but are interested in getting caught up on some of the topics that we've covered, have a watch or listen to our previous conversations on the Bombas YouTube channel. In the past, we've spoken about the unique realities of women experiencing homelessness, food insecurity, farming and sustainability, racial equality and empowerment, and which was our first topic, how to talk about homelessness when it can feel like an overwhelming topic and conversation. But let's get into tonight's topic. When I was first thinking about this topic, I was thinking about a headline that I'd read that named homelessness as a public health crisis. I typed those words out, wondering if they might accurately frame this conversation. But when I read those words back to myself, I considered how they might possibly be misunderstood, that there might be this perception of blame rooted in that phrasing, that there is a public health crisis and homelessness, and the entirety of those who are experiencing it is to blame. This thinking, of course, does not at all represent how I think about it, nor how I think we should be thinking about it, but it did make me pause to consider the notion of blame. So often, our health and the way we perceive the health of others is rooted in feelings of blame or shame. There are so many I should haves or they could have, and that blame and shame is so often a barrier to getting the help and support that someone needs. Of course, to counter those feelings and hesitancy to get help, we need to answer to a health crisis with compassion, support, and dignity, building a system that allows for meeting someone exactly where they're at. And we know that systems don't change overnight, unfortunately, but fortunately, there are people who are making change every single day. And a few of them are here with us tonight, representing an organization that's close to my heart, Boston Healthcare for the Homeless program. I'm so pleased to introduce our speakers tonight. First, I'm happy to introduce Evan Russell. He's a nurse practitioner who has worked at Boston Healthcare for the Homeless program for 4 years. He works in primary care and on the office-based addiction treatment team in clinic and on the community care InReach mobile care van. Evan was the associate medical director at Boston Hope COVID-19 shelter, established by the city of Boston in partnership with BHCHP, and runs the Sublocade program at BHCHP. When he's not assisting patients with their recovery, he enjoys trying new restaurants with his wife and watching 80s action movies with his cat. Samantha Sirocco started working at Boston Healthcare for the Homeless in August of 2019 as the clinical operations manager for the office-based addiction treatment program and became the director of telemedicine in 2020. She graduated from Simmons School of Social Work in 2014, where her clinical focus was on the treatment of trauma and substance use disorders. Prior to working at BHCHP, she was a clinical social worker in the emergency department on the inpatient addiction consult team at Mass General. And in addition to providing therapeutic interventions to patients with substance use disorders, she also manages grants pertaining to increased access to, I knew I was going to not pronounce this right, buprenorphine and telehealth. Thank you, Evan. Is part of the quality and improvement team and developed the mental health and substance use disorder protocols for Boston Hope, again, the COVID-19 field hospital. And she's been an instructor for multidisciplinary education events for some really wonderful places like Mass General Hospital and Harvard Medical School. She has a strong interest in providing low barrier, high quality treatment of substance use disorders for vulnerable populations, including racial and ethnic minorities, those with histories of incarceration, and unstably housed communities, as well as reducing the stigma around medication and mental health treatment within each of these populations. And next, Travis Henderson, who's been working at Boston Healthcare for the Homeless for the last 2 years after doing his final year of practicum there. Prior to graduating with his MSW from Boston University, he spent 3 years teaching preschool with Horizons for Homeless Children in Boston, receiving awards for creativity and lesson planning and execution. He's also worked with children throughout Boston Public Schools and in homes as an applied behavioral analyst technician. He began working in homeless shelters at the age of 16 and has worked with homeless populations in Philadelphia, Boston, and Calcutta. Additionally, Travis has worked in residential treatment facilities for children aged 7 to 18, providing drama therapy and group-based therapeutic interventions. As a licensed clinical social worker in BHCHP's respite program, he also provides group-based counseling support, individual counseling, and therapeutic interventions while advocating on behalf of patient needs. Most recently, Travis presented at the National Healthcare for the Homeless Conference around the value of peer supports in respite during the pandemic. So these folks really know their stuff. They have had an incredible amount of experience, and I'm excited for us all to be able to learn from them tonight. First, the question that I'd like to start with is, I would love for the audience to get to know you all a little bit more beyond the introductions that I just gave. So much of where we're at now is thanks to our own journey. Will you each tell us a little bit about what got you to where you are now? Samantha, let's start with you, and then Evan and Travis.
Yeah, sure. Thank you for such an amazing introduction. I think, when I was working in the emergency department at Mass General, I noticed very early on that my favorite patients were people who were unstably housed and came in all the time, and often had significant trauma histories and substance use disorders, and were really just looking for some kindness and compassion and humanity. And I was able to offer that. And I really, after being able to do that for a few years, really, it sent me on the trajectory I'm now. And I really sought out a position working within this population so I could do that all the time instead of just when those patients came in.
Thank you, Evan.
Yeah, I think I knew I wanted to go into nursing and become a nurse practitioner someday. And I think, early on, we all have like some encounters we think of when we think of a homeless person and what that might be like or what their lives might be like. And I think before I even went to nursing school, I had volunteered here just to see what it was like as a program, and meeting so many really fascinating people, not only patients, but employees, and the patients in particular, just learning about their resilience and, how far either circumstance or the system can push people, but they still get up and do their best and, try to take care of themselves and make at least their world a little bit better. I was really, really impressed and fascinated. And it's really wonderful to work with folks in that kind of situation every day. So that's how I ended up here.
Amazing. Travis.
Yeah, as you mentioned, I grew up working in shelters, food kitchens, doing programming for kids in shelters. And after time in I don't know, I just kind of always found myself drawn to populations of people who were housing insecure. And as Evan said, just constantly in awe of and humbled by the work. And so it just continues, right? Why would I do something different when it's a gift to get to do what we do. Yeah.
And BHCHP truly does sound like an incredible place. And even just in the short amount of time that we got to chat before going live, it seems like the camaraderie among the folks that work there is something very special. And I'm sure all of your patients really feel that. It seems to come through. And I think we'll all hear a bit more about it as we get into the conversation. So just to give the audience a little bit of context, I'd like to define public health, which I think sometimes can sound a little bit nebulous. Evan, will you tell us what it means within the context of your work at BHCHP?
Yeah. So I'll first say that I think public health is a very nebulous term because it really does, I'll quote my wife here. She works in public health, and public health is everything, really. I mean, everything you can think of somehow relates to public health. So it's a weird term, very, very broad. But I think as far as our work goes, it's thinking about, in a traditional sense, if someone comes in because they have high blood pressure, okay, maybe you can look at that as a silo. Like you have an individual, their blood pressure is too high, you got to bring it down. But in our world, it's a little bit more nuanced and complex. You have to think about, okay, well, where does this person live? What's their diet like? Do they have much control over that diet? It's hard to say limit your salt intake when you have zero to no input on what you're eating. Where they store their medication, the level of stress that they're under. And so appreciating the public health sense in a broader sense as in, not just medicine, not just psychiatry, not just their physical, emotional well-being, but everything around them and how that impacts this one individual. It's like, trying to isolate one plant in a forest, wherein it's affected by everything else that's going on in the forest. That probably didn't make it any less nuanced, but that's my pitch.
No, I think you definitely helped to paint the clear picture, especially the consideration of how interdependent it all is. And to try to address something in a silo is so challenging, which I think we will talk a bit more about. So thank you. Samantha, you've done so much work to develop and implement protocols that focus on supportive intervention for substance use and mental illness. First, what do you wish more folks better understood about the use of substances as a coping mechanism?
I mean, there's so many things, but I really think, drugs, illicit or prescribed, are there to treat something. That's why they exist. If something's not working, your doctor prescribes you a medicine for it. Some of those ailments are easier to treat. And broken bones heal with the right medicine and physical therapy. But when you're using substances to make mental health better or like trauma exposure, like a little more tolerable. You're not using illicit substances that aren't prescribed by a doctor to have fun, to party. You're really trying to self-medicate many like trauma exposures, reoccurring trauma, community violence, generational traumas, systemic, racial. I mean, our patient population, everyone has such a significant trauma history. And what makes trauma more manageable and is really long, prolonged therapy. And it's really hard to do that when you don't have a stable environment to practice those coping skills in a healthy, safe, supportive place. But substances are instant gratification, and we are an instant gratification society. And that's no different for people who are unstably housed. There's something that hurts, and there's something out there that'll make it better. So I don't even think that, saying a coping skill, that's not like a deep breathing exercise that a therapist would like help you learn and develop to help treat anxiety. We're really looking at the intersection of trauma and how it impacts someone's mental health and that reoccurring trauma. And, it's really hard to manage all of that and everything else that our patient population is faced with. So if your trauma exposure and your PTSD prevents you from going to the doctor or going to a housing appointment or going to the dentist, but it's more manageable to do that if you use substances and you're able to take care of those other things, then people are going to use substances, and that's okay. We will worry about the other stuff later. We'll teach you how to use substances safely to be able to use that as an immediate coping skill, so you can work on those other things, and that will hopefully lessen the plate load to then be able to work towards any goals that someone has about their mental health.
Absolutely. And I think you really did touch upon this two-way connection between mental illness and substance use, and how sometimes they can be conflated, but the importance of looking at them as an interconnected thing, but also separately to best help address an individual's needs. Evan, do you have anything else that you'd like to add to this topic from your perspective?
Yeah, I mean, that was great, Sam. I think, there's such a stigma, and I think we'll talk about this later on too, but like both substance use and mental health are highly stigmatized in our society. And I think when you start to open the conversation about one or the other, people have a preconceived notion, and it's hard to change that idea sometimes. But again, there's so much nuance, right? Like you can use a substance in a safe way. You can use a substance in a disorganized way. You can have symptoms of, depression and anxiety that are manageable, and you can have some symptoms that are unmanageable and you need help, whether it's therapy, medication, something else. So there's a spectrum, but immediately people's guards go up, or, they start to have judgments, preconceived or otherwise, as soon as you start to talk about them. And so I think, trying to put those judgments aside, put those stigmas aside, and open up honest conversation is really important, to make any sort of headway, whether it's for the patient or for the public at large.
Absolutely. And I think, just to take it also back to something that Sam had said and that you touched on, Evan, is the idea of making a traumatic experience more tolerable. Sam, I liked that you called it out as not a coping mechanism per se, but something that can be used to lessen the feeling of a traumatic experience, to be able to get through what you need to get through to address some other concerns. Travis, is there anything else you'd like to add to this?
Two things that help me kind of frame the thought here is, one, everybody is doing the best they can at any given moment, and two is people make sense in context. And so if you kind of capture those two things as you kind of enter into spaces, it helps lead with empathy, it helps lead with humility, to just understand like everybody you meet is doing the best they can at any given moment, and people make sense. That's all I'll add to that.
It's such a powerful reminder. Well, keep talking with you, Travis. You've cared for so many individuals around the world. And in Boston, you currently provide care for those in BHCHP's respite program. I've long been impressed with this program. Too often in New York, I see individuals who are experiencing homelessness who have been discharged to the streets without the proper aftercare and support. And through COVID, through my own volunteer advocacy work, I saw and experienced firsthand how challenging it was to fight for the right accommodations for individuals who really needed that critical recovery care. Will you tell us about this aspect of BHCHP's programming?
Yeah. So overview, it's a 104 bed program. It's the largest respite program in the country, also the first. Really, really lucky to be able to work in a place that just like cares about giving care, right? And can offer a wide lens around what that might look like. So basic premise is like, if we can extend our lens of care, if we can extend the timeline that we can engage with somebody with unconditional positive regard and non-judgmental kind of like love, then over the course of time, we see dramatic changes, right? But in a day-to-day, it may not look like that. And so the respite program really allows us to meet people where they're at with complex medical needs that are really serious and sometimes totally separate and not connected to any kind of active use, but sometimes they are. And so to be able to provide care within the context of wherever a patient is at really allows for that lens, that timeline to begin to extend. Talking before again with Evan about we shared a patient who was at our respite program who wanted to connect to office-based addiction treatment and said, I'd like to do this, and run downstairs and find Evan. And Evan, can you come up and meet this patient? It's all COVID and everything. Evan was able to kind of like articulate an amazing care plan. I took a video of it and I ran back up to our respite program and like sat down with the patient again and able to show the video. And they're like, oh, and that's going to be my provider. Like, yeah, that's going to be your provider. They'll be able to come see you like even next week while you're here, right? And like in a vacuum, when you try to like nail down like, oh, in 2 weeks, this is what we're going to accomplish. Like it can feel very hard to get something done, right? But if you view it within the lens of like, what we're doing here is we're offering love, right? And we're building a relationship with a person in our community, then like all of a sudden now you takes the pressure off of one moment and you can just care for somebody, right? Wherever they're at. So that's what our respite program really, I think at its best takes advantage of. And it's a real gift when our patients come in, like tell everybody, thank you for being here. Thank you for letting us care for you. Because for our patients, like they don't often trust people to do that. And like what they're offering us is trust, which is kind of like the highest degree of honor you can do. So like it's a real gift when they come in.
Truly. And I love that you said that you all truly care about caring for people. And I think that you're right, that isn't always the case with every interaction that a lot of folks have. So being able to help them gain that trust through your program is just so beautiful. And speaking of meeting someone where they're at, which I think we'll continue to talk about, is such an important theme. During COVID, so many services went virtual, challenging the way that we connected with each other. And telemedicine, though certainly not new, saw a huge increase in utilization. Sam, how has telemedicine been especially beneficial for reaching individuals that might not otherwise have been able to connect as easily?
Originally, when you think of telehealth, which is something I've been seeing my therapist via telehealth for years, but no one really thought of it in the context of treating unstably housed populations. A lot of people we care for don't have homes. They don't have access to food. They don't have access to chargers to charge a cell phone or Wi-Fi because all the libraries and Dunkin' Donuts and Starbucks were closed, or privacy, even like to be able to have a dignified space to have a telehealth visit. And COVID kind of made us realize like we either figure this out or people aren't going to get care right now, because a lot of our patients have co-occurring medical conditions that would have made them very vulnerable to the COVID-19 virus. So what we did find, interestingly enough, and I mean, we had a lot of external partners who were providing cell phones so we could give them to patients, and calling cards. And I mean, we were very fortunate about how the community helped support us, support our patients. But we found like an increase of behavioral health appointments. Everyone was scared, everyone was nervous, everyone was anxious, but they could call their therapist on the phone when they had those feelings. Our no-show rate reduced. We didn't have to worry about, oh, does this patient have the money to physically get to clinic for their appointment, because they could talk to their provider via Zoom or on the phone. And then I also think, for at least in Boston, a lot of our shelter sites were decongested. People were sent to these pop-up shelters all over the city. And they couldn't leave because then they'd have to get like COVID tested if they walked out of the doors. And like us being able to leverage telehealth for this population allowed to make sure that people's blood pressure was still managed with their provider via telehealth, their psychiatry appointments, even dental appointments, to some degree were able to happen via telehealth. And I think there's a huge misconception in society that people without homes don't care about their health. And I think what we found with telehealth is that if we reduce as many barriers as we can to accessing treatment, they actually want to engage more. You know, we're in their community. Like we share the same goals and the same values with our patients. And you know, now I have patients who will call me and be like, hey, is it time for our therapy visit? Like, how's your weekend? And I'm like, you're not, like, the relationships have just been made so much more robust because the access was so much more available, that you were able to build therapeutic relationships with your patients. And it was just like a beautiful thing to see. And I'm so glad that Massachusetts has allowed like telehealth to continue and be able to be reimbursed, especially for behavioral health. And that will be here to stay, because if you reduce all the other barriers of like time and money to get to appointments or even find parking, or, you know, people want to engage more, but society makes it hard. The system makes it hard, and telehealth just makes it so much easier.
That you touched on a question that I had about the ability to continue those services, and what an incredible silver lining I suppose this is to find out through being forced to be a bit more innovative in connection. So there, in your work, and Travis and Evan and yours too, do you see greater opportunities to be able to continue serving your patients in this way?
I mean, I personally think so. Yes, but I also think that we learned a lot from being able to quickly pivot to telehealth, because what we really learned is that the easier we make it for people to engage in healthcare, the more that they will engage. But I think Travis and Evan might also have other perspectives on.
Yeah, I mean, by far, like, especially in primary care, for me, it was great because you have sick people who you want to see more often, you know, because they have heart failure or COPD, but then you don't want to be like, you're sick and that puts you at a higher risk for a bad COVID case. So please brave the waters of COVID to come in so I can listen to your lungs and make sure you're okay. And then go back out into that environment. Like, to just talk on the phone every week. How are you doing? Are you taking your meds? Any issues? Anything new? Okay, cool. We'll check in next week. Yeah, a game changer by far. And then when things got bad, we really needed to see somebody in person, you could bring them in, and more often than not, you had the availability and the space in your schedule because fewer people were coming in. And so that made it a little safer. It really worked out well. And yeah, there were like kinks and things at the beginning, but it was great. And for, you know, the OBOT team too, doing the Suboxone prescribing and following up. I mean, that's really meeting people where they're at. People live chaotic lives, and not everybody has a wristwatch and, can schedule their 11 o'clock appointment to show up exactly 5 minutes on time. So some people show up hours later, or they were able to secure a couch somewhere on a buddy's apartment, but they had to travel all the way across town. That's fine. Skip my appointment. Just call me on the phone while you're heading there, and we'll do it on the phone. So it's been great. Too bad it took COVID to get there, but great.
Absolutely. It sounds like that element of control too that we've been touching upon, just that ownership over experience and ability to be able to manage it in a way that feels true to each person is so wonderful. Travis, do you have other experiences that you want to touch upon?
Just the kind of ability for patients to reach other resources too. So I'm thinking specifically around 12 steps and recovery-based peer supports that suddenly became accessible all the time. And so, you don't have to find a meeting in a church basement at 2 o'clock that you didn't know about. You can just go on to Zoom and there's a meeting for anything all the time now. And for our patients to develop a comfort level with that, it's just, as both Sam and Evan said, another way in which when we lower what makes it hard to do something, more people want to do it.
And I think that's true for all of us. We are much more likely to do things when it's easy. I want to pivot slightly just to get into the topic of choice and dignity of choice. A little example of something that happened last weekend. My mom and I were walking around the city, and we observed a woman with a to-go bag of food approach a homeless gentleman who was sitting on the ground with a sign asking specifically for money. And this woman walked over and offered him the food, and he said that he didn't want it. And she countered by saying that he should accept it. Again, he calmly declined her offer. And not wanting to back down, she then placed the bag near him, insisting that he have it, saying that it's good food and he should take it. She started to walk away, and then he got up and took the bag, walked across the street, and placed it in the garbage. At which point, the woman who offered it got really upset watching him do this. And I was getting kind of worked up watching it happen, and I couldn't help but speak up and say to her, it's okay that he doesn't want it. You offered it and he said no. Respect his choice. There's dignity in respecting someone's choice. And I imagine this is something that maybe we've all witnessed or experienced at some point. Certainly, our intentions come from a place of wanting to help, but forcing what we think is good upon someone is not usually the answer. How can we shift our mentality and do our best to strike a balance to ensure that we're helping in a way that somebody wants to be helped? Evan, what do you think?
Yeah, I mean, I think that those particular people, the person with the bag and the person who didn't want the bag, I think there's a little bit of a degree of maybe I'm helping you and I want the gratification of helping you. So don't take that from me. And it comes from a good place. I'm not judging this person at all, but when we get caught up in that sort of charity and righteousness, and it gets muddy. And who knows what was in that bag? Maybe the guy just doesn't like hot dogs or whatever she was offering him. But you need to meet people where they're at. They need buy-in if you're going to make any progress at all. You can't force someone to make a change if they're not ready to make a change, or they just flat out don't want to make a change. And that's a huge part of what we do on the OBOT team. We don't say you have to completely swear off drugs to be part of care here. If you just want to get high Monday, Wednesday, Thursday, or whatever, and the rest of the days you don't want to use, cool. That's a great goal. Let's start there. Let's make sure that on the days that you do use, it's safe and you don't overdose and nothing bad happens. And then, thank you, office-based addiction care. And on the days that you don't, let's make sure that that feels right for you. And we'll meet you. And so if you relapse, don't feel bad, don't feel ashamed. One of the providers on our team, he always says that like shame is not beneficial because, and we know that from studies, from experience. And if we thought shame helped anybody, then we would be shaming people. That's what we would do if we thought it helped, but of course it doesn't. And so, yeah, this woman with the lunch, great intention, but let him live his life and figure things out.
Thank you for that. Travis or Sam, do you have anything you want to add to that?
I mean, I think I could talk for an hour just myself about the importance of dignity and creating a space where that it is dignified. Yes, like Evan treats people on a mobile van, and during COVID, that van was closed and he was treating people on the sidewalk. And Travis is frequently also seeing his patients after they get discharged from respite out in the community. And, eye contact, learning about like smiling when you make eye contact, not crossing the street, like all those things that seem little really are huge for our patient population specifically. And I frequently, when I see people and I'm like, hi, how are you? I'm probably the first person that's asked them that all week. So I always give the space to listen, because they want to tell me. It might not be why we're meeting, but I want to give them the dignity to like tell someone how they're doing and ask that question. And that's really how you build relationships and ego strength. And ego strength is such an important part of improving any aspect of your life. And that all starts with like dignity in healthcare, dignity and access to resources. So I think that's like a great question and a great thing to bring up. So thank you for giving the space for that.
And I'll only add seeing a person in context, right? Like a whole person. So in your story, you described two people. We don't know either of them. We don't know anything about either of them. We know that there was a lunch and someone didn't want the lunch and someone wanted someone else to have a lunch. And that's all we know. We don't know more or less than that. And like, I think oftentimes we see a thing and we feel all these things based off our own personal experiences and histories and understandings. And that's what gets thrown out there. And like, the reality is like, we don't know. We don't know so much. And I think like leading with curiosity over like a judgmental mindset is oftentimes very helpful. Because again, if you operate with the baseline belief that everybody's doing the best they can at any given moment, and like, boy, I wonder what's happening in both of these people's lives, right? Like now you can be curious. And I'll give an example, and not to counter the eye contact thing. Eye contact is wonderful, but I was sitting with someone and they said, yeah, I have a really hard time with eye contact. And I switched my seat and sat next to them and faced ahead. And they looked at me and said, what are you doing? I said, you told me you didn't want eye contact. That's cool. And like, that was a moment for them of being heard, right? Like, and for me, it's great. You just told me your needs. You know how many people like never do that? I had to guess half the time, but like, you just told me what you need. You gave me an opportunity to listen to you. Again, a gift, right? Not how many of us just feel so guarded sometimes. We don't trust that anybody's going to listen to us anyway. So those are things that come to mind for me around like dignity.
I absolutely love the leading with curiosity. I think that's so important. I mean, in everything that we do, really, but you're right. I mean, our own experiences lead us to have a snap judgment based on what we think we're observing. But if you can take a step back and lead with that curiosity and ask yourself questions, even if you won't get the opportunity to ask them out loud, I think it lends itself to so much more of a compassionate mindset as to what you might not know. So I think that's such a good reminder. And the benefit of ego strength, Sam, I mean, I just think about sometimes if I'm walking around the city and I have a ton of stuff to do and I'm angry or irritated or whatever, and maybe someone shouts out that they like my shoes or something, and like instantly I feel my mentality shift and I'm like, oh, and I'm pulled out of my mindset and I just feel more human. And it's to be able to give that to someone that might receive that kind of interaction even less, or be able to build that ego strength, I think is such an amazing reminder. um, let's see. So we've talked a lot about dignity, and I mean, I think we have touched upon it a lot. We naturally evolved to getting into it, but I think it's also a topic that we could talk about for an entire hour. Is there anything else around the importance of dignity, or the ways that you're enabled to offer a dignified experience that you want to share about? And we might have covered it already, but I just want
I'll just put out there, kind of in the way we started talking about like healthcare as a was it nebulous kind of topic. Like I think trauma is also kind of like that too. So the only thing I would put out there is like, when we talk about kind of working with and in and around chronic or even acute and singular instances of trauma, it's never one thing. And so I just want that said there. Like when we talk about trauma, we're not talking about one specific thing. We're talking about like either a series of or ongoing instances of, or sometimes one instance of all these different things, but they have a material and chemical impact on both the brain functioning, but also on behavior and patterns of behavior.
Would you talk a little bit more about that too, Travis? Just through the experience of trauma and ongoing trauma, or trauma that's not yet been able to be addressed, also the way that can compound some of it can show up as a physical manifestation, or just how it can further deepen the impact on a person, and perhaps also touch a little bit on, just to help someone best understand the physical demands of being having housing instability, or experiencing homelessness.
Sure. So someone in the chat, so shout out, someone in the chat brought up the ACEs study, which did a better job than I ever will around describing kind of the impact of these instances of, right? And then combined with, as we think about like how we learn to cope with things, right? Some of them work sometimes and then they stop working. And then like the lengthened course of treatment around like what treatment for complex trauma would look like versus the immediate need to alleviate symptoms. That's all very dynamic, kind of a lot there. It can start really, really early. And so early life trauma impacts a developing brain in a way that sometimes is forever. Babies who are crying are communicating, and in call like toxic stress, right? So like extended toxic stress, the communication parts of your brain are cut and they don't work as well. And it's going to take a lot of work to get back to that. But you'll never do that work if you're always in this toxic stress, if it's never addressed, right? So it can continue to snowball. And then like poverty, right? So poverty is in and of itself a ACEs risk factor. But then like what happens in specifics around generational poverty, or violence within poverty, and these all kind of compound too. And then you talk about somebody who's 47 and they've been doing the best that they can for 47 years. And now you're meeting them, right? And like the gift that this person is giving you by allowing you to care for them, like can't be overstated. I'll leave that there. I imagine Sam and Evan will have good things to say also.
Yeah, I mean, so you've touched on the ACE study. The person in the chat touched on those. I mean, for anyone who doesn't know what ACE is, it's the Adverse Childhood Events study. Came out in like the late 90s, I think. And yeah, it basically took, I mean, anyone who took like high school social studies remembers Maslow's hierarchy of needs, the little pyramid, where at the bottom was like basic safety, like a roof over your head and water and something to munch on. And then there was like family and friends and safe, like emotional security, and all the way up to self-actualization. The ACE study basically proved that in that hierarchy, if you're missing the bottom rungs, you're going to have a negative health outcome later on in life. And then it's not just like your life's going to be a bummer, but like your life is going to be complicated by medical complications. And so, yeah, I mean, when you think about, you know, the environmental factors of what it's like to live on the street, you know, you don't get clean drinking water. You're probably breathing in car exhaust all the time. You're not sleeping well. Like, even just on a purely physical level, you're enduring things that we really weren't designed to. You know, we're a communal species. We need to take care of each other. We need to be indoors and felt like we're wanted. And being thrown out into the streets or into a shelter, it robs people of their humanity a little bit, and dignity, like we were talking about earlier. But can lead to emotional, physical, medical outcomes that are pretty negative.
So for family shelter systems, so first time, like if you're a mother, say single mother, and you're entering into the family shelter, you get 2 trash bags worth of stuff. So everything you own down to 2 trash bags, that's what you get to bring with you. If you're entering into as a single person in a shelter, not even that, you'll get your bag that you can carry, and you'll probably use that as a pillow so no one takes it, and they still might. Shelters themselves can be not so far from the street as there is. And then over time, the kind of amount of engagement you have with various systems, right? So the shelter system, the hospital system, the incarceration system is oftentimes plays a part. We criminalize homelessness, we criminalize poverty. And then because we are here with Bombas, so thank you for having us, feet, the care of our patients' feet, it is singular in its difference. So like our patients' relationship to their feet is so different than a lot of other populations. Because they're on their feet. I was hoping someone would jump in there.
Well, I work closely with one homeless woman, and she often laughs to me about her feet are her vehicle. And when she's had to undergo recently a foot surgery, and just how challenging it's been to try to help manage care for her when any patient would normally be told to stay off their feet for 4 weeks or 6 weeks, and that just simply isn't possible to her, which is drastically extending the length of her recovery and care. And we're doing the best that we can, but I think it's something that is too easily overlooked.
I mean, I have a patient who had a relapse, and in that relapse didn't change their socks and ended up having an infection in their foot and lost pieces of their foot. It's tragic.
Yeah. And I suppose too, for folks that have an inability to lay down or spend too much time sitting up and sleeping up or walking for very many hours of the day, I remember being surprised when I first really learned about that impact and just how problematic it can be to the swelling of one's feet and foot health issues, just simply by not being able to lay down.
Yeah, there have been multiple studies that have linked homelessness as a factor of mortality. That, whether if you had 2 people with the same heart condition and one of them is homeless, that person is more likely to die. And it's shameful. I don't want to get too political, but it's shameful that we live in a place where, 2 people are put in different positions like that.
Absolutely. Evan, let's talk a little bit more about your work with the mobile caravan and the topic of resiliency, which all of these folks have. I imagine that many of the folks you interact with are some of your community's most vulnerable, and the resiliency is often overlooked, I think. I don't think that we give folks enough credit for how resilient they are. Will you share with us a bit about, and Travis touched on this a little bit, the difference between staying in a shelter versus living on the street, which sometimes can actually be deemed a rational decision, knowing what shelter situations can sometimes be like, and just how important is that resiliency and helping to encourage that in your patients?
Sure. So yeah, we are very lucky to have a mobile caravan. It's a mini Winnebago. It's got a whole clinic on it. It's got a little sofa where people can hang out. We partnered with the Kraft Foundation, MGH, and our local syringe services, A-Hope, which are right next door. They're a bunch of really, really groovy people. And so an average shift, we go out and usually by the time we've parked the van, we go to the same spot a couple times a week throughout the city. And usually folks are there waiting for us, either to pick up some syringes and substance use supplies, or to check in for a quick visit with me or one of the other providers. And then if it's quiet, we'll go out in teams and sort of do a little bit of exploring. I usually go down by the North Station area, and we poke around under the Zachem Bridge and other areas to try to find people who have sort of chosen that place as their encampment, which is exciting on one hand, because you want to find people where they are. But there's also a concern that if you sort of bring too much attention to where they are, that other entities will also notice them and ask them to leave or push them to leave. But it's the most striking thing, I think, is even outside of the shelter system, where in a shelter you may have hundreds of people living in some giant warehouse and social cliques develop. But out on the street, part of the resiliency is the community. So you have people from any of all possible walks of lives who, by circumstance or otherwise, are put in this position where they sleep on the street in all kinds of weather that Boston has, from awful to ugly. And they lean on each other. They support each other. They share food. They swap clothes. Like, there's almost this like communal property. Like, what's mine is yours. We'll share a sandwich. We'll share an umbrella. And it's all, I think, founded in necessity, but also compassion. Because I think they recognize what maybe society has robbed them as far as that needed compassion. And they're able to generate that while they're dealing with everything else they have to deal with, and share it with each other. So being able to go down and meet those people like in their environment, get to know them and participate in their care is hugely gratifying.
Sam, did you want to add to that?
I just also want to comment on the fact that, like, when you add in mental illness or severe mental illness diagnoses, shelters are really scary places, especially for like a female who has a sexual assault history, or someone who is the victim of community violence, stabbing, shooting. It's really hard to feel safe when you don't know who all's around you, or when you're going to get woken up at 6 a.m., but your PTSD nightmares don't let you fall asleep until 4 a.m. And it's often safer for someone's mental health and their sense of security to sleep out on the street in pocket communities or by themselves because of that. So it's also really important to remember, like, if you see someone sleeping on the street, that is 9 times out of 10 a choice that they are doing to contract for their safety. And I don't think people see it that way. because shelters aren't for everyone, just like, living in condos or 5-floor walk-ups, or like, we all have our own level of tolerance to things, and shelters can be hard places. So I'm very thankful that like people are able to make communities and safe spaces and then still engage in healthcare with people like Evan in Boston.
Travis, do you want to add anything?
I have a story comes to mind about a patient who didn't like to be inside almost ever, and so one of the things that happened during COVID is people didn't often have that choice, right? And so to say like every patient who came in and was cared for during COVID did so as a gift to their community, especially those people who didn't have any symptoms and who we were saying, yeah, you got to be here for the next 7 to 12 days. And everybody in here does have COVID. And the amount of people who didn't trust lots of systems, not excluding us as a medical system, didn't trust the news, didn't trust what was anything, and they allowed themselves to be cared for. It's kind of amazing baseline. So this patient comes in, he was just not happy about being there, and he had some pretty serious wound care that needed to get done, but he decided he didn't want to be there with us, so he left. He chose to leave. This wasn't during COVID. This is in our respite program. So I see him again in about 2.5, 3 weeks. He had come back and he had shared that he had reached out to the local sex workers in his homeless kind of community and had paid them to do his wound care. And he did that for like 10 days before he decided to come back and get more supplies. And he stayed for 2 weeks that time, right? So it went 3 days to 2 weeks. And then, and you're just building this trust right over time. And you're just kind of in awe of this human who doesn't need you at all, as far as that, like they're going to handle it. And when they allow for care to come, it's a real gift.
I'm just so encouraged by the continued reference to your ability to be able to care for someone as a gift. And I think it's such a wonderful reminder and humbling reminder of the dynamic too. I guess there's only time for one more question. So if there is one thing that you would like to share with the folks who are watching and hope that they'll take away with them and maybe share with another person, what would it be? Sam, let's start with you.
Gosh, one thing, probably that everyone's a person and should be treated as such. And society is only as strong as their, most vulnerable person. I don't really like calling our patients vulnerable because they're the strongest people I know. But humanity and dignity and kindness go a long way. And like, just because you aren't lucky enough to have a roof over your head or access to, food every day doesn't mean you don't care about yourself. And I think that's an important lens to use when just even like passing by someone who's building a shelter on the street, that they really are doing the best they can.
Evan, what do you think?
Yeah, I mean, I think whether you're spiritual or not, I feel like there's this golden rule of like, you just treat people the way you want to be treated. And I think that should apply to anything in anyone's lives. But I think also, particularly with homelessness and with healthcare in general, like treat people the way you'd want them to treat you, cut them some slack, and, we'll all get along a little bit better and things will be more groovy.
Close this out, Travis. What are your words of wisdom to leave us with tonight?
the results you see are the product of a system designed to create the results you see, and that we all have a part to play in things kind of becoming more loving and more empathetic. So all of our decisions matter.
Yes. Well, it is 7 on the dot. Thank you, Travis, Evan, and Sam, so much for joining us tonight and for sharing your expertise and experiences. I'm so grateful that we have the chance to learn from you all. And I know as much as you're so grateful for the folks that you get to hold your trust and interact with, they're so lucky to have you three as well. And I feel so grateful that you're serving the Boston community in such a beautiful way and a groovy way. So thank you. And thank you to everyone that joined today. We've recorded tonight's conversation, so we'll be sharing it on our YouTube channel if you want to share it out with anyone. And we hope to see you at the next conversation. Good night.